So T1, T2 flare, and then things that we're not so used to in general as radiologists because they were always so difficult to acquire, like a double inversion recovery sequence. So in addition, we have synthetic maps, as I said, and so I'll talk about Philips because that's what I use. So basically, for Philips, we can use our compressed sense AI in order to accelerate our scans so we can make them clinically useful in very quick acquisition times, as you'll see moving forward. So for us, the sequence is currently approved for neuro, spine, and knee. And we view it not just as a research sequence anymore, but rather it's part of our ubiquitous routine imaging that we do. And from that, we can also get quantitative data. So it's become a very core sequence to our neuroradiology program. As I was saying, so I'm the director of I'm a cardiac imager by training who's kind of evolved over the past 10 years. Our neuroradiologist is, she comes from a quaternary care center. She came to us 6 months ago. And so we've developed the protocols with her in order to optimize everything. So the standard out-of-the-box sequence that you'll get with Philips is a 3.7 AI factor, so with a 5 millimeter slice thickness. So what we've done, looking at the images, there were some mitigation strategies that we had to do, which again is part of the beauty of this sequence. You actually have the ability to play around with it in any way you want, not any way, in several ways that you want to make it look appealing to the radiologists that you're trying to serve. So for us, we found a 4 millimeter slice thickness was the right way. Our neuroradiologist and me, for that matter, complained that there was a bit of hyperintensity that we're not used to seeing in the cerebellum. By decreasing that to 4 millimeters and employing some other mitigation strategies like changing the field of view, we were able to mitigate that and make it clinically pretty, basically. So this is our standard brain protocol. It's a 3D T1 with compressed sense, smart diffusion, susceptibility weighted imaging. So if you're a Philips user, we run it with a compressed sense AI of 10. And our MDME, 4 millimeters with a CSAI factor of 6.4. Our recon voxel is like 0.3. So really high resolution in the axial plane. So here's what we get in 6.5 minutes. So standard 3D T1 TFE with gray-white differentiation. Standard DWI, standard SWI, both. The combination is 1.5 minutes. And then we have a 3-minute approximately. Anyway, all these are acquired all at the same time. The T1 flare, the T2 flare FATSAT. Again, we opted for FATSAT because it was visually more appealing to us. And a double inversion recovery, which is something that, again, most radiologists are not used to seeing through the full brain. So from this, we can also get, we're into our cases. Perfect. So the first case is optic neuritis. So this is an MS patient. So this is probably one of the main use cases for synthetic MR. So we can see this patient with MS, and you can see several lesions. Here, one in the corpus callosum, one in the right frontal white matter. So all of this acquired in one single 3.5 minute acquisition. So, and now this is part of the real beauty here. So this is something that you can't get in any other sequence. So this patient has MS, and I'll draw your attention to those, the blue arrow and the red arrow. So with the blue arrow, you can see what healthy white matter has. It's 40% myelin concentration. So you can see that right here. The myelin is all aggregating into the white matter. In this lesion, we have a bit of normal white matter included. So you can see the normal white matter here, but then there's signal dropout. And we can actually quantify that now for the actual amount of myelin. So 8.7%. So you can see that the myelin density is actually impacted. This is something we could never see before. And if you think forward to what you can actually do with that in terms of follow-up imaging for patients, it's now not just lesion load, but you can actually quantify the density of the myelin loss. So are they losing myelin? Are they maintaining myelin? Or hopefully in the future, are they remyelinating these lesions? So here's another case, 70-year-old with white matter microangiopathy. The question was, do they have dementia? So again, we AI boosted synthetic MRI. So what we found here is basically the myelin map is coming lower than two standard deviations. So again, there's clinical merit to that, in that these studies have shown that in patients with dementia, their myelin fraction is actually diminished as compared to their normal age-matched controls. So the synthetic MR map, the graph, which is automatically generated, comes age-matched. So this is a 70-year-old woman. So you can age-match to exactly where their myelin should be. And so in this patient, the myelin is actually decreased as compared to normal. So really powerful stuff that we had no way of quantifying before. So again, now that we're into cases where we're just showing what it can do. So as I said, we use this ubiquitously now. So basically, this patient had a motion artifact, but the sequence we found is completely robust even with patients with motion artifact. So in the Philips world, we use multi-vein a lot of the times in order to change step blade, propeller, and other vendors. We still have to use it, but we don't have to use it all the time in order to get the images. So again, 3.5 minutes, the patient is in and out. So this is real benefit to throughput for us. So this is the quantitative neuro report that we get. So again, we really like this. So probably hard to see, but you get a brain parenchymal fraction, myelin correlated fraction, which is age matched to what normal is, full myelin volume, CSF volume, brain parenchymal volume, as well as an intracranial volume. The intracranial volume is basically used to normalize to get all this information. So now moving on. Again, I'm trying to show these kind of standard ubiquitous use cases for most people. So this is a standard MDME sequence. Again, you can see the hemorrhage in this patient in the left parieto occipital region. And then this is an interesting case. So in the PD map, we can actually see this lesion out here. This is an undifferentiated complaint. So it's tweaked our interest into, hey, is there actually more that we can see here with these T1 and T2 maps than what you could appreciate before? This is totally nonspecific, I'd submit, on all the other sequences. Ultimately, this patient has breast cancer. So is that something? Well, we're not sure yet. More research is needed, but it's really something that kind of excited us when we saw it. So this is another case of a prior papilloma resection. Again, the T1 and T2 map beautifully show the cystic cavity. We can be more confident in our diagnosis that there's no evidence of recurrence. Okay, now we're moving on to the spine imaging. So we didn't really anticipate doing spine imaging with this when we first started. But we were very happy with the neuro image quality. So then we started to work on our spines. So again, I think this is a 4.5 minute acquisition. So all the tissue weighting is required simultaneously. So this patient obviously has a cord compression. So I'll tell you a few things about this case. I really love this case. So cancer patient, obviously. So what you can see here is obviously the vertebral body fracture. Now I'll submit to you this collapsed vertebral body there's a questionable amount of stir signal that you can see. But once you move here to the PD map, you can see that it's different than all the rest of the cord. So that allowed us to be a lot more confident in our diagnosis with respect to whether there's actually cord change there related to this metastatic deposit. The other thing that I really like about this case, bring your attention to this hemangioma. Bright red, light bulb. And now one level down, the metastatic deposit, blue, completely blue. So I've found this consistently now over several cases. We've run overall about 100 cases. We've run a few spines, but I've consistently found the hemangiomas red, the metastases blue. So really gives you a bit more understanding what's actually happening. Now, the question is, the problem cases for a radiologist are when that T1 is not super bright. So how is it going to look at that point? Remains to be seen. I'll be feeding that back to you guys when I eventually see a case like that. So the other thing, this cancer patient, I'd submit that these are pretty normal. Now, there's a couple of studies that show good correlation of the PD map with actual bone density. So what we've also found, what I've anecdotally found, is that in these cancer patients, I often see red. In young, healthy patients, those vertebral bodies are blue. So we're seeing marrow changes here that we previously couldn't see. So I'm really curious to see what it actually means, but there is some type of marrow change that's happening with respect to these particular patients when they get chemotherapy. So again, standard case, this is all acquired at once. I think this is a 3-minute acquisition. So T1 flare, T2 stir, PSIR, PD map in this patient was discitis. Again, you can see the image quality is adequate to make the diagnosis in this very uncomfortable patient. So we could get everything we needed in 3 minutes, 3.5 minutes. So now I'll move on to some standard use cases that we're using ubiquitously in our practice now. So we've used this in a standard seizure protocol. So what we run is a coronal angled sequence, angled through the temporal lobes through the whole brain. So because of that, we can get a white matter and a gray matter double inversion recovery. Again, these are things that typically you're doing narrow sequences right through the temporal lobes just to get a good picture. Now I can get it through the whole brain. So I can really see the gray matter and the white matter to much better advantage in order to make a diagnosis of potential seizure focus. So, and what we've found, even in the coronal angled plane, we're still getting robust quantitative data. That's no different than our out-of-the-box axial sequence. So this is a 5-minute acquisition with, again, but we actually increase our resolution probably to about 0.3 by 0.3 on the recon voxel with a CSAI of 4.2, 5-minute acquisition. So this is what we get. So again, you get PSIR maps, which again, things radiologists are typically not used to looking at. So again, it shows the gray-white differentiation a lot better. So if there's hypointensity on this particular sequence in the gray matter, it's indicative of a seizure focus, which previously it would be really difficult to pick up on standard T1 weighted imaging. So more from our standard seizure protocol. So now we get this gray matter map, which in seizures is hopefully important. Again, once I see a positive case, I'll send it along. But we have a lot more data than we had previously with our seizure protocol in a 5-minute acquisition. Again, so in our orbits, what we've done is run an even higher resolution with the smaller field of view, so that we could get a better view through the orbits and the optic nerves. Now, one of the beauties of this is the T1 and T2 maps, because often in the optic nerves, it's very difficult to get a good sense of what's actually happening. here you actually have internal controls. So once you get into the body of the optic nerves, you have a T1 and T2, which you can compare the sides to. So because of that, you can be a lot more sensitive to your diagnosis, because before we would obviously need to see signal change. Now, the T1 and T2 maps are a lot more sensitive to those signal changes that you can see as opposed to our conventional grayscale imaging. So standard C-spine imaging. So we've basically been able to optimize our protocol to 2 minutes and 50 seconds. And from that, we used to run a T1, T2, and stir in about 7 to 8 minutes with compressed heads. So now we're down to 2 minutes and 50 seconds for the exact same information. But we also get a PSIR for that, plus the PD maps and any other weighting you want to include. Again, most of our radiologists, myself included, are pretty stuck on the T1, T2, and stir. But there are some who want something different. And again, with this, it's kind of individual radiologists can choose the sequence that they want to look at the time. So this is how it looks. This is our, I'm not sure how old this patient is, but this is our standard C-spine, 2 minutes and 50 seconds. And then our standard lumbar spine, as we've talked about. So this is from a paper. So again, the PD map has a good correlation with bone DEXA, and we found that to be somewhat useful. So what are the future directions here? So right now, our MDME sequence is limited to 2D. We've seen multiple cases of 3D imaging at the booth. So we've dropped the 3D flare that we really like from our standard brain protocol, but we still run our 3D flare and everything else that's not a standard brain protocol. So our post-GADs all get a 3D flare. Basically, our seizure still gets a 3D flare on top of everything else. So, but that's coming. We know that's coming. We've seen it. So, and then there's work being done on breasts. And then I'm hoping in the future there'll be triggered and navigated sequences that I can run in cardiac. So right now we standardly run a T1 and T2 map on every one of our patients. And that will hopefully be replaced by the synthetic sequence at some point in the future. So for me, anecdotally, I think the T1 and T2 maps, again, I'm from a cardiac background where we use it all the time. I think these T1 and T2 maps elsewhere in the body are going to be a really big deal, because all of a sudden you're gone from having different imaging, which varies based on flip angle, echo train length. You can no longer standardize at that point. But with these sequences, they're ubiquitous. They're the same across vendors. They're the same across sequences, basically. So 1,000 milliseconds is 1,000 milliseconds at 1.5T, no matter how you scan it. And that gives a vast array of data that we just simply couldn't get with MR in the way that it was currently scanned. So I personally think that will then get taken into the research field and used in order to generate these normative data. And from that, it'll further refine our ability to detect pathology. So that's what I have for you guys today.